This training video is sponsored by the Tennessee Department of Mental Health and Substance Abuse Services in partnership with the Tennessee Association of Mental Health Organizations, TAMHO. Funding was provided in part under Grant Number 6, H79SM08-6148, the Substance Abuse and Mental Health Services Administration, SAMHSA, U.S. Department of Health and Human Services, HHS. The views, policies, and opinions expressed are those of the authors and do not necessarily reflect those of SAMHSA or HHS. This learning series is entitled Substance Use and Youth at Clinical High Risk for Psychosis. This presentation examines the intersection of clinical high risk, CHR, for psychosis and substance use, highlighting the impact of substances like cannabis on psychosis risk and symptom severity. It provides an overview of key drivers of substance use, assessment strategies, and evidence-informed treatment approaches tailored to CHR population. Learning objectives include 1. Recognize the link between substance use and clinical high risk, CHR, for psychosis. 2. Explain the role of various contributors to substance use among youth at CHR for psychosis. And 3. Distinguish between substance-induced psychosis and primary psychosis disorders in CHR individuals. Presenting this topic is Dr. Jason Schiffman. Jason Schiffman, a professor at the University of California, Irvine, earned his PhD in clinical psychology from USC. His research advances the identification and treatment of individuals at risk for psychosis, focusing on refining diagnostics, implementing psychosocial interventions, reducing stigma, and promoting health for all. With over 200 publications, he has secured over $20 million in funding, including several active NIMH grants involving individuals at clinical high risk, CHR, for psychosis. Dr. Schiffman co-founded 3 university community partnerships, including a SAMHSA-funded CHRP program, and is among the few certified trainers of the structured interview for psychosis risk syndromes. He also consults for CHRP programs nationwide. Join me in welcoming Dr. Jason Schiffman.
Hi, my name is Jason Schiffman, and today we're going to talk about substance use and youth at clinical high risk for psychosis. All right, we got a big agenda here. We'll talk about psychosis and clinical high risk for psychosis first, and then we'll go through a variety of different topics here from psychoactive substances, substance use and CHR statistics, links, and why there's these links between substance use and CHR. We'll do a deeper dive on cannabis and CHR, talk about some clinical strategies, and then even like a clinical strategy vignette at the end for just to kind of think through some things from a practical standpoint. Briefly, what is psychosis and CHR? Well, just want to highlight a few things here, and that schizophrenia is the hallmark disorder associated with psychosis. Psychosis is a broader term that's specific to symptoms, and it doesn't. Schizophrenia always has psychosis symptoms in it, but psychosis isn't always driven by a schizophrenia-like process, and in many cases, it could be driven by substances. And so that will be in large part the topic of what we'll be talking about today, and beginning to try to parse out how do these things overlap, how do these things cause one another, how do they intersect. Now, risk for psychosis, or the clinical high risk for psychosis phase, that's the time that precedes a threshold level of full psychosis. And it's really important because if we can find folks during this time, before they've developed psychosis, we can partner with them and work with them to help potentiate positive outcomes, including outcomes such as a lack of use or abstinence from substances of abuse. I think it's important to understand schizophrenia and psychosis risk on a continuum, and understand how they relate to one another. It gives us a better sense as to the progression and development, and also the signs and triggers that we might be able to see before symptoms become so more debilitating and distressing for a person. Psychosis has a variety of different definitions. A couple here that I have is a severe mental disorder in which contact with reality is lost or distorted. I think that's a little technical for me. I like the second definition that I have here from the National Alliance on Mental Illness. It says, psychosis is characterized as disruptions to a person's thoughts and perceptions that make it difficult for them to recognize what's real and what isn't. There's a humanizing element to this definition where it puts the onus of responsibility or the generation of symptoms on the fact that a person is having trouble with how they're thinking or how they're seeing the world. And that makes it hard for them to recognize what is real and what isn't. It's a little more humanizing. And what then the sequelae of having a challenge between understanding what's real and what isn't leads to some of the hallmark symptoms that we understand with psychosis, which include things like delusions and hallucinations. Delusions are here you see false and fixed beliefs or ideas that are held onto tenaciously despite evidence to the contrary. Now, delusions and hallucinations fall into the category of what are sometimes referred to as positive symptoms. And when we talk about positive, we don't mean things that are good, but rather things that are added to a person's reality. Um, delusions, false, fixed beliefs, they might sound like, I think people are talking about me, or someone's following me. They can be more elaborate, like people are plotting against me, or aliens are sending me messages through the TV. Now, it's important to remember these experiences exist on a continuum, like I was emphasizing earlier. Many of us have had moments where we wondered if people were whispering about us, or we misinterpreted a look or a comment from someone else. In psychosis, or even psychosis risk, those thoughts become more fixed, more distressing, and harder to shake. But recognizing that there's a shared human starting point helps us connect, reduces stigma, and reminds us that anyone can struggle with these experiences. The more we can relate, the more inclusive our communities become, and the more likely people are to seek and receive help. Hallucinations, the other symptom I have here as a positive symptom, these are sensory experiences without an external source, like hearing, seeing, or feeling things that others don't. Auditory hallucinations or hearing voices are the most common. And again, there's a spectrum. Think about hearing your name when being called when no one's around. Like that happens to a lot of people. For most, it's fleeting and it's easy to dismiss. For others, experiences like that can be persistent and intrusive. Understanding the range helps us respond with empathy instead of fear. And there's a variety of different implications for psychosis that I'll share with you briefly. But psychosis in general affects about 1 to 3% of the population worldwide. This equates to about 100,000 adolescents developing illness related to psychosis for the first time every year in the US. The impacts are almost sort of hard to overstate. One of the most appalling statistics in this field is reduced life expectancy by 20 years. So people with psychosis are likely to die 20 years earlier than people without. This is schizophrenia in particular, I should say. A risk of loss of life is in large part driven by risk of death by suicide, although that's not the only contributor. Quality of life, family functioning, independent functioning, educational attainment, all these things are impacted by psychosis. And the disorder is economically taxing as well, with estimates being at about almost $350 billion per year in costs, both indirect and direct costs. And interestingly, this has doubled in the last in 6 years. There was an estimate coming up from 2013 where it was about half that you see in the 2019 estimate. Now, although there are some challenges associated with psychosis, I want to emphasize that many folks who experience psychosis can and do lead full and successful and satisfying, meaningful lives, lives of their choosing. We call this recovery. And we should be thinking about recovery as the expectation and not the exception. Now, one of the things that potentiates a healthy recovery is early identification leading to early intervention. To further the motivation for this type of work and serving people in the earlier phases of psychosis, I want to share this figure with you. And if you imagine this arrow is the passage of time, and the second arrow pointing down that says onset of psychosis is when a person crosses threshold for psychosis. And the arrow to the right of that is when treatment starts. The duration of time between these 2 points is referred to as the duration of untreated psychosis. And in the US, the average length of duration of untreated psychosis is anywhere between like 13 months to 24 months or so on average. So that is an appalling statistic in and of itself, that people are living in the community with a diagnosable illness related to psychosis and not getting effective care. Now, there's a problem there. And we can help address that by working with people in the clinical high risk phase of illness, or CHRP, or the attenuated phase of psychosis. And you see here that risk box. That's where we can connect with folks to partner with them, such that if, unfortunately, they are destined to develop psychosis, we can reduce their duration of untreated psychosis to 0, give them a warm handoff to the kinds of care that they need. Or in some cases, we may be able to delay, if not prevent, psychosis from ever emerging in the first place. Now, the reason why this is so important is because duration of untreated psychosis is associated with pretty much anything negative that you can imagine. So the longer the time period between the onset of psychosis and the start of effective treatment, the worse outcomes are predicted to be. You see things like worse long-term outcomes, more intensive needs for services, more negative symptoms, social impairment, educational, occupational impairment, distress, and costs and burdens to the system. Now, there are reasons for this. Without early intervention, individuals face significant obstacles to receiving help, which drives why DUP, or duration of untreated psychosis, is bad. This includes issues like lack of motivation or insurance, negative first experiences with treatment that predicts lack of engagement with treatment in the future, or miscommunication with professionals where the messages of hope aren't as readily expressed or heard. All of these barriers can discourage people from seeking or continuing treatment, which can be detrimental to their recovery process. Now, one of the things that contributes to some of these negative outcomes, and that is associated with longer duration of untreated psychosis, is substance use and addiction, which will be the primary topic of our remarks today. But before we dive more deeply into substance use, I want to say this. One way to reduce duration of untreated psychosis is to find folks before they develop psychosis. And that, I've been alluding to this concept during our first several minutes together, but we call this time the time before psychosis, the clinical high risk for psychosis phase of illness. Now, what is this? The DSM defines it as follows. At least one of the following symptoms, and those symptoms are delusions, hallucinations, or disorganized speech, is present in attenuated form. Now, the word attenuated means thinned out or lessened, subthreshold to full psychosis. So similar in nature to psychosis symptoms like delusions, hallucinations, and disorganized speech, but less in terms of severity or intensity. The definition continues by saying, with relatively intact reality testing, which suggests that the person has some insight. They know that what they're experiencing might not be real. It might just be in their head, but they're still struggling with it or wrestling with it. Then it goes on to suggest that it's of sufficient severity or frequency to warrant clinical attention. And what this implies is that it's not just an experience that the person's having or a set of experiences or extraordinary experiences, but rather it's symptomatic. It's getting in the way. It's doing something in their life such that services or mental health care would be beneficial to address it. Okay, and you see here some pages from the DSM. There's a billing code associated with it as well. And when we talk about clinical high risk for psychosis, we're also referring to the state that the DSM uses, the attenuated psychosis syndrome. The symptoms are there. They may not be full threshold. They are not full threshold in most cases, but they do exist, and they're distressing in and of themselves. So in a way, they get in the way of life. They're interfering. They bother the person, and they can impact how a person is living and thriving in the world. So, irrespective of whether or not they predict future conversion to additional psychosis severity or not, being in the risk phase is a mental health concern in and of itself. And it's also predictive of future deterioration, making it doubly important to address. All right, so I thought I'd read a vignette with you to emphasize what CHR might look like, or clinical high risk for psychosis might look like. And this is of a person named Sarah. So Sarah reports worrying that people can read read or hear her thoughts. She explains that this concern often arises in social situations, particularly when she feels people are paying attention to her, amplifying her sense of vulnerability. She notes that certain triggers, such as overhearing a conversation, can heighten this belief. She's unsure of why it starts, but knows that logically it's not possible, but can feel real in the moment. She believes this to be connected to the thoughts that she has about others' opinion of her, particularly in moments of insecurity or self-doubt. It makes her feel fearful of judgment and can be preoccupying. She indicated that her worry about this really stresses her out. She sometimes, quote, tests it out, in her words, and begins thinking things to get a reaction, but has never confronted someone about it. Instead, she monitors others' body language or expressions for signs that they might be reacting to her thoughts, which she can sometimes, which can sometimes increase her preoccupation. Okay, so a few things to highlight here. In terms of the description, what's going on with Sarah? She's really describing that people can read or hear her thoughts. So the first thing that we want to understand in terms of context that will help us get a better sense of the texture of what's going on for Sarah and what's driving her challenges includes a description of the primary symptom. And in her case, this makes her feel vulnerable. She notes that certain triggers, like overhearing a conversation, can heighten a belief that others can read her thoughts. Now, the next thing, and some of these things overlap, but the next thing that we want to think about in terms of getting a better context for what's going on with Sarah is her level of conviction. How much does she believe in this? This will give us a sense as to whether or not this is psychopathology, or if it's risk for psychosis, or if it's full psychosis. Now, it says here she's unsure of why it starts, but knows logically it's not possible, but it can feel real. And then she has some explanation for this going on. But the fact that she's unsure suggests that she has some level of insight and doubt, which would suggest that if we believe that this is on the psychosis continuum, it's in the risk range and not full threshold psychosis, because with full threshold psychosis, you see full conviction and no doubt can be induced with respect to the belief in the experience. The next thing we sometimes think about to get more context is level of distress. So this line highlights that she's fearful and she's worried and stressed out. So this isn't just an experience; it's an experience that's bothersome to her. It's distressing to her. It's negative. Then the last thing that I want to highlight that we sometimes look for is whether or not there's behavior change. So when we're thinking about CHR, we look for the description of the experience, level of conviction, distress and interference, and if the person does something different in response. That gives us a sense of intensity and how much it's sort of getting in the way of their life. She's testing things out and she's monitoring people's behavior to get a sense as to whether or not they might be able to read or hear her thoughts. And that would give us an indication that this is more than just a fleeting experience, but this is something that she is acting upon. Okay, so that gives us a sense as to what CHR and what psychosis is all about and the importance of early identification and intervention. As we continue to push forward, now I want to segue into the intersection of some other elements that are the focus of our conversation today. In particular, now we go into psychoactive substances. Now, this slide, it provides a brief overview of common substance categories and their primary characteristics, along with like two representative or examples of each or so. Starting with cannabis. It's known for its mind-altering effects, with marijuana and THC in particular being the most common examples. Alcohol, classified as a depressant, slows down brain activity. Beer and wine. I won't spend much time talking about alcohol today, nor will I spend much time talking about hallucinogens. But hallucinogens like LSD and psilocybin, these alter perceptions and can lead to experiences that actually resemble psychotic symptoms, such as vivid hallucinations and paranoia. But these effects are often temporary. Stimulants, cocaine, methamphetamine. These increase dopamine, which can lead to symptoms like paranoia, delusions, and auditory hallucinations. They tend to abate, though, after the substances clear the system. Opioids include heroin and morphine. These can cause dissociative states or hallucinations in some cases. And particularly during withdrawal, the symptoms that relate to that seem like psychosis can come into play. The sedative effects of these drugs can also make early signs of psychosis harder to see. So it could delay diagnosis and treatment in some cases. And then the last one that I have here up on this slide are steroids, such as anabolic steroids and testosterone. These have been linked to aggression, mood instability, and sometimes psychotic episodes or episodes of psychosis, especially when used in high doses, especially when used for prolonged periods of time. This condition has like a name, sometimes referred to as steroid psychosis. It usually will resolve once a person stops using steroids. Okay, setting the table. That set the table for some of the substances we'll talk about. But when we talk about the downsides of substance abuse, it's important to look at how it affects both individuals and communities as well. So first off, there's the physical damage, like things like alcohol and opioids can really have implications for our organs, leading to serious health problems and even overdose deaths. Then there's the impact on mental health, which also is very hard to overstate. Using substances can make existing issues like anxiety and depression worse, can even bring on new problems like psychosis. Now, on the social side of things, substance abuse can strain relationships, lead to isolation, and result in poor performance at school or work. There are also legal issues to think about, like many substances are illegal, and getting caught can lead to problems in the legal system that can hurt future work or just a future in general. Financially, of course, the costs can pile up from buying substances, paying for legal trouble, healthcare. Plus, you might lose income due to lower productivity. Finally, addiction. Addiction creates a tough cycle where people keep using substances even when they know it's causing major problems. This is particularly worrying for those at clinical high risk for psychosis, since using these substances can make symptoms worse in some cases and increase the chances of developing a full threshold illness related to psychosis in some cases. Substance-induced psychosis and primary psychosis can appear very similar, with overlapping features like hallucinations, delusions, and disorganized thinking. The key differences emerge when you look more closely. I want to highlight a few of these. The first is about the temporal relationship or timing. Substance-induced symptoms tend to emerge during use or shortly after, whereas primary psychosis, it develops independent of substance use. Resolution is another thing that we can look for. So with substance-induced episodes, symptoms often ease once the drug's effects wear off. In primary psychosis, they persist well beyond the use period when the person has finished using. Severity and duration comes up as well. Here, episodes linked to substances, they're usually shorter, briefer, and they can vary from one instance to the next. Now, whereas primary psychosis is generally long-standing and stable and much more consistent. There's information to be had with respect to pattern in history. So if the onset of symptoms repeatedly follows substance use, then common sense would suggest that there's a good chance that that substance use is the cause related to the issue. What about the effect of abstinence, sustained recovery during a drug-free period? That tends to point towards substance-induced origins or etiology of the challenges. While, of course, ongoing symptoms, despite abstinence, would suggest psychosis is really more at play. And then symptom patterns. Of course, this one is another common sense one when it's clear, but oftentimes it's not clear. But some substances have characteristic effects, like stimulants leading to paranoia, hallucinogens leading to perceptual distortions. If the symptoms aren't overlapping with what you would expect to see, but they are in the psychosis spectrum, it might be that psychosis is the origins or the etiological contributor there. And then the last thing I'll talk about here is associated signs. So Withdrawal symptoms or intoxication, these often accompany substance use and induced psychosis. But negative symptoms or more long-term disorganization, those are more typical of primary psychosis. And of course, there's interplay between specific substances and the symptoms that they would be expected to see. So anyway, a good general overview of how we can try to understand the overlap and also the key differentiating factors between substance-induced and a primary psychosis disorder. One way that you can get a little bit more in depth here is to dive deeper into a comparison between substance-induced psychosis and schizophreniform disorder. So I've broken this down into different factors here, while to give you a key comparison between a particular disorder related to psychosis and substance-induced psychosis in general. Now, when it comes to timing, symptoms from substance use or withdrawal, they show up in connection with drug use. Like while schizophreniform disorder, those symptoms just sort of happen on their own without an identifiable point or etiological contributor. As for how long they last, symptoms from substance use usually clear up pretty quickly after the substance is out of the system, whereas schizophreniform disorder, it tends to persist or stay around at least for 6 months or longer, if not. Now, the cause is another big difference. Of course, substance-induced psychosis comes from the effects of the substances. Meanwhile, the schizophreniform disorder causes, we can't really pinpoint or put a finger on exactly what's causing it, but it's some internal process that is not likely driven by the substances if it persists. Negative symptoms are a last thing that I want to emphasize, like having flat affect or lack of motivation, much more common in schizophrenia spectrum disorders like schizophreniform disorder. You don't see them as much in substance-induced psychosis, although some aspects of withdrawal might look like negative symptoms as well. All right, so our next section is about substance use and CHR statistics. So digging a little bit more into the intersection between substance use and clinical high risk for psychosis. Substance use disorders are a notable concern at individuals at clinical high risk for psychosis. And you're going to hear me mention a lot of different stats. The truth is, we don't exactly know the exact stat on anything in this area. So consider what I say as indicative of ranges. In general, you'll see higher substance use among those at clinical high risk compared to healthy controls or people in the general population. At initial assessment, like around 11%, a little more than 10% of folks at risk for psychosis are found to have any substance use disorder, one or more. But over time, this increases, the prevalence increases to about 19%, almost 20%. Now, a significant portion of this is due to cannabis, with approximately 13% of folks at risk for psychosis impacted by cannabis use. This is much higher among males in particular. In what's referred to as the Naples 2 study, which is one of the biggest studies on folks at risk for psychosis, one of the, especially in North America, we see like a bit more of a detailed breakdown. At baseline, 5% of the sample met criteria for cannabis use disorder, followed by 3.2 meaning for alcohol. And these findings, they emphasize the importance of early screening and intervention for folks at risk for psychosis. Because although the numbers aren't more than 50% or whatever, the implications are quite significant. And substance use disorders, they can exacerbate the risk of future development of full psychosis, not just risk for psychosis, and certainly impair functioning for this particularly vulnerable population. Let's talk more about cannabis. Now, there's a comprehensive review from Ferris and colleagues in 2020, and it highlights the complex relationship between cannabis use and individuals at clinical high risk for psychosis. Now, They suggest that nearly half of CHR folks have used cannabis in their lifetime, with over 25% reporting current use and 15% meeting criteria for cannabis use disorder. Now, while cannabis use is associated with an increased risk of transition to psychosis, they report that the data suggests that cannabis may primarily contribute to individuals entering a CHR state rather than directly causing psychosis. So once a person is at risk for psychosis, their data suggests that it doesn't increase risk for transition from that point all that considerably, but it will get them to the risk state as an initial trigger. Now, what's interesting is that there isn't strong evidence that shows that cannabis really changes symptoms, cognitive function, trauma history, or family history related to psychosis in a significant way. These insights, though, they highlight the need for focused prevention efforts because what the data does show is that folks who start using cannabis early and who use high doses and who use high concentration THC are at greater risk than people who don't have those risk factors for developing full psychosis in particular. So be on the lookout for that. And if your client is showing signs of psychosis and they're using cannabis, this is a warning for them to recognize that there could be future implications for their long-term mental health concern related to psychosis. Reported alcohol use in CHR populations, that ranges from, let's say, 17 to 50%. Interestingly, folks at CHR are not heavier alcohol consumers than the general population. However, they do show a higher likelihood of meeting the criteria for alcohol use disorder compared to their peers. Now, let's see, moving to tobacco. Tobacco use among folks at risk for psychosis varies. 16 to 53% of the estimates that are out there. What stands out is that that for folks at CHR, they're almost 2.4 to 4.8 times more likely to use tobacco than the general population, indicating a notable disparity. This is very true for people with full psychosis or schizophrenia in particular, where 2/3 of folks with schizophrenia or so roughly will smoke, whereas less than around 15% in the general population will smoke. I will say this: there's no solid proof that alcohol or tobacco actually cause someone to develop psychosis. So neither of these substances are thought of as causal agents. So it's important though clinically though, because these are unhealthy uses. But there's a lot of people use these substances that are at risk for psychosis, but not really considered a trigger for psychosis. Okay, so let's switch gears now to drivers of the link between CHR and substance use. Like, why? Why is there a connection between substance use and risk for psychosis? And I want to delve into this why question. Why is it that individuals at CHRP seem to have a greater inclination towards substance use? Now, some ideas to look at include the self-medication hypothesis, dysfunctional coping mechanisms, and biological sensitization. Start with the self-medication hypothesis. It suggests that people at CHRP, often turn to substances like cannabis and alcohol to ease distressing symptoms such as anxiety, depression, or even mild psychotic experiences. Even though these substances might give a quick break from discomfort, that short relief can make people want to use them more, hiding the health risks that come with using them over the long haul. Next, dysfunctional coping mechanism is another hypothesis as to why people at CHR might use substances. Many of those at CHRP, they encounter significant levels of stress, trauma, or social challenges, and they may struggle to access healthier coping strategies. In such situations, people might start using substances as a way to cope with their emotional pain, which can cause them to lean on those substances even more. Additionally, biological sensitization presents a neurobiological perspective. Now, individuals at CHRP, at risk for psychosis, in other words, They may show heightened dopaminergic activity or other neurological or neurobiological sensitivities that make them more susceptible to substance use. This increased sensitivity can enhance the pleasurable effects of substances, raising the likelihood of continued use. I got more here. There's a lot of reasons that I want to highlight that. Here I want to highlight social influences. And in this slide, I cover cognitive vulnerabilities as well as neural developmental challenges as well. Now, first, social influences and peer pressure. These play a significant role, especially for adolescents and young adults. Those at CHRP are often part of social groups where substance use, particularly cannabis and alcohol, could be normalized or even encouraged. And peer approval and social modeling can heavily influence behaviors, increasing the likelihood of substance use in individuals who experience these types of pressures. Second, cognitive vulnerabilities. These can further compound the risk. CHR states are often associated with deficits in cognitive control and decision making, which can impair judgment and make individuals more susceptible to substance use. For adolescents, the susceptibility is exacerbated by the early onset of cognitive impairments, making them even more vulnerable during this very critical developmental period. Neurodevelopmental vulnerabilities also contributes to the connection between CHR and substance use. Adolescents, in particular, they bring out, or adolescence as a phase brings out shared traits like impulsiveness and willingness to take risks, which often get ramped up during this time. These overlapping traits can lead to both CHR symptoms and substance use happening together, creating maybe a tricky cycle that makes intervention even more challenging. All right, so to finish our exploration of the link between CHR and substance use, I want to dive into four additional key factors that deepen our understanding of this complex relationship. Now, first is reward sensitivity, then co-occurring mental health disorders, and then cultural and environmental factors, as well as genetic or family risk. Now, reward sensitivity can play a big role. Now, folks at CHR, they may have an altered reward system, which makes them more sensitive to the immediate positive reinforcement offered by substances like cannabis or alcohol. Even when aware of potential harms, the heightened sensitivity to these rewards can drive continued use. Co-occurring mental health disorders frequently complicate the picture as well. Folks at CHRP, they often experience high rates of anxiety, depression, personality disorders, etc. These additional challenges can make substance use a coping mechanism for managing distress, for trying to address these mental health challenges, but also further entrenching the maladaptive behaviors. Environmental factors can also significantly influence substance use patterns. For example, in regions where cannabis is legal or culturally accepted, its use may be more prevalent, which might put people at more risk. Additionally, systemic issues such as marginalization and limited access to mental health resources can push individuals towards substances as a means of escape from the stressors that they might be dealing with. Finally, I have genetic and familial risk also contributing here. Those at CHR, they might be more likely to have a family history of both psychosis and substance use issues. Since these conditions can run in families together, it's important to tackle them from a holistic perspective. And that last line, a holistic perspective, I have literally dedicated 3 slides to why there might be a link between CHR and substance use. There's a good chance that all of these links intersect at some level for people. It's unlikely to be one thing that's driving this, but rather a whole portfolio of different factors and their intersection with one another that are contributing to why there is a link between folks at risk for psychosis and substance use. Okay. Now, I've covered a little bit about cannabis and psychosis already, but I want to dive a little bit deeper because there's a lot of growing evidence that shows that cannabis is, in fact, a prevalent substance among youth experiencing psychosis, 54% or higher, And heavy cannabis users have a fourfold increase in their risk of developing psychosis compared to folks who don't use cannabis. With the average user having about like a twofold increase, but heavy users fourfold. Adolescents often report using cannabis to fit in socially, to improve mood, or to cope with symptoms and with anxiety. And the anxiety, or excuse me, this developmental window is the point of greatest vulnerability for people that might develop psychosis. The risks are heightened even further for younger users and those consuming high potency cannabis strains. So, from a neurobiological perspective, cannabis use can have profound effects on brain structure and function, particularly in adolescents who are vulnerable to psychosis. Now, studies reveal reduced gray matter density and alterations in dopamine systems linked to high THC exposure. Additionally, the endocannabinoid systems, which is influenced by cannabis, may contribute to psychosis risk. We're not really sure how that might work, but there's some biological evidence to suggest that. Um, all these findings emphasize the complexity of cannabis's impact on the developing brain, especially in those already vulnerable and maybe have some sort of biological vulnerability to developing psychosis. There's more to be understood with respect to cannabis's link to clinical high risk for psychosis, but what we do know now is that cannabis seems to put somebody at a heightened risk of either developing clinical high risk for psychosis symptoms or developing full threshold psychosis. All right. I wanted to share a few studies from my lab that we've done in this topic. I won't spend too much time on this or any one of them, but I do want to touch on some of the main points that we've been able to uncover in this space. My first foray into this field was really like over 20 years ago. And it was a simple study I ran looking at temporal precedence. What comes first? I didn't think much of it actually, but the attention this study received helped me realize how controversial this topic was going to become. This study explored the relation between schizotypal traits, which are akin to or similar to risk for psychosis traits or symptoms, and cannabis use. By analyzing data from, we had almost 200 undergrads. It found, what we ended up finding was that cannabis users displayed higher cognitive, perceptual, and disorganized schizotypal traits, so traits related to psychosis risk, with symptoms typically, but of course not always, typically emerging before cannabis use, around age 13 for symptoms, and then cannabis use coming a little bit later, around age 15. Now, this study, it modestly suggested that for some, not all, but some, schizotypal traits may increase the likelihood of cannabis use rather than vice versa. But the reason I highlight this study is because this line of work back many years ago really gained a lot of attention in terms of people being interested in the link between cannabis and psychosis. And that fervor, that energy, that interest in this area has only increased over the years. Now, this study involved 174 youth and their parents to explore cannabis use and attitudes among individuals with clinical high risk for psychosis symptoms and healthy controls. Data collection occurred before and after legalization of cannabis in Colorado, highlighting the effects of changing legal contexts. Cannabis use was significantly more prevalent among youth at CHR compared to their healthy counterparts, with with use often driven by peer approval, low perceived risk, as well as parental permissiveness. Importantly and interestingly, post legalization of cannabis, these attitudes, especially peer and parental influences, became even stronger predictors of use in youth at CHR. And even though parents at CHR became less permissive, the amount of permissiveness remained a very high predictor of use. This highlights the need for interventions that address social influences, parental attitudes, and education on the risk of cannabis, particularly in environments with changing legal and norms related to cannabis use. All right, this next study, study 3, cannabis use increases the risk of psychosis We do seem to know that, but we don't yet know who is most vulnerable or when. Evidence does suggest that there's an interaction between genetic vulnerability and cannabis use, though we currently lack the tools to identify the genetic vulnerability. Now, what this study did was it examined young adults' attitudes towards a hypothetical genetic testing for cannabis-related psychosis risk. And participants who were presented with a scenario of either a 2% risk of developing psychosis when using cannabis or a 10% risk of developing psychosis when using cannabis. And willingness to undergo testing and intention to avoid cannabis were significantly higher in a 10% risk scenario, particularly among cannabis users. Overall, these findings, they highlight the potential of genetic testing as a tool for risk communication, encouraging healthier behaviors and enabling targeted interventions to reduce cannabis use in genetically at-risk populations as our sensitivity and awareness of biological risk factors continues to grow and emerge. This one's not really a study, but I thought it worth mentioning as it describes some of my thoughts on this nuanced topic. We explore the trade-offs between mental health risk associated with cannabis legalization, like psychosis as a trade-off, and the societal costs of its criminalization, especially mass incarceration, affecting certain communities. We ultimately advocate for a balanced approach that includes regulating cannabis potency, harm reduction strategies, and addressing potential legal system issues that might make some folks more vulnerable to negative consequences than others. By investing cannabis tax revenues into mental health services and public education, we think we can mitigate risks while also promoting equity and public health. In the end, we believe that this type of approach has the potential to lead to healthier and more just society. Okay, I want to talk briefly about clinical strategies, and I want to frame this to suggest that the clinical strategies here are pretty broad. I firmly believe that people at risk for psychosis are far more similar than they are different from people not at risk for psychosis. And if you take that assumption, then the strategies that we're going to use that help support people not at risk for psychosis are going to be effective for those who are at risk for psychosis, with some adjustments and tweaks needed from time to time. Now, there is nothing CHR specific in this resource or in this section in general, but what we do here is a quick screen for substance use that's just as relevant for those at clinical high risk for psychosis as anyone else. If you want to dig deeper into substance use assessment, a tool you could consider that's even deeper than this is the structured clinical interview for psychosis. The structured clinical interview for the DSM-5. But for a quicker approach, consider these 4 steps. These are an assessment and treatment planning approach. The first step involves asking the client about their past year use of substances, including alcohol, tobacco, and other drugs. And then based on that, based on the responses there, we determine if further assessment is necessary. If there's no need, if there's no substance use, there's no need to keep going. We just reinforce their abstinence, and that's it. We complete the screening. But if there is use, in this next step, step 2, we're asking about a person's lifetime drug use. Start by letting them know this is something you ask everyone. So it normalizes it. It creates a sense of lack of judgment that you're just learning this to help partner with them. And there's nothing about them that you're trying to single out. But then you just go through the list from A to J in terms of substances. If they say yes to any item, we'll follow up with more detailed questions for that specific drug. If they say, if all are no, and their earlier screen was also negative, move on. You don't have to do any more screening. But the key is to be straightforward, non-judgmental, and clear that this is about lifetime history, not just recent use, so you can get more depth of information. All right, so this keeps going. If the patient reports any lifetime drug use, we now go drug by drug. So the first in question 2 Ask how often they've used that substance in the past 3 months. If the answer is never, skip ahead to question 6 for that drug. If they've used in the past 3 months, continue going on. So continue with question 3, frequency of strong desire or urge to use. How often use has caused health, social, legal, or financial problems. Question 5, how often they fail to meet obligations due to use. Question 6, has anyone expressed concerns? 7, have they tried and failed to cut down? And then 8, any history of injecting drugs? And then you record the answers on each of these. This brings us towards step 3 and step 4. Now that we've gathered the detail on frequency, cravings, problems, and attempts to cut down, we total the score to determine a risk level for each. We can get a low risk, we can get a moderate risk. These folks may benefit from brief advice, motivational interviewing, short-term counseling, and then high risk. Here we take a more intensive approach, generally speaking. Feedback, assistance, and hopefully, if available, arranging specialty treatment if needed. The key is to match the level of intervention to the level of risk with enough support to address the problem without over or under intervening. All right, another screening tool that I wanted to highlight is not for substance use, but rather for risk for psychosis. So as these two concepts overlap, we have substance use screening and we have CHRP screening. So what we recommend is a very brief basic screening. What we found is these two items are pretty sensitive to a person's vulnerability to psychosis risk or clinical high risk for psychosis. These questions include, do you ever hear the voice of someone talking that other people cannot hear? And have you ever felt that someone was playing with your mind? This is a very brief general screening. If someone scores high on this, either one, or if someone says yes to either one of these screening questions, the first thing that I recommend doing is to have a conversation with them, learn more, listen, get a sense as to if their interpretation of the question is the same as the meaning that's intended from the question by the authors of those questions. In other words, when they're saying yes, are they saying yes to, in their mind, a question about psychosis, or are they saying yes to a question about something else? Having a conversation really gets to the heart of that and can quickly lend clarification. Then create a plan. That plan could be a treatment plan. It could be additional assessment. If it's additional assessment, then specific assessments for clinical high risk for psychosis could be really relevant. But so too could be assessments for substance use. And asking some of the questions about substance use from the screener that I just put forth before can be a part of a comprehensive evaluation. And if they're not using substances, then that screener gets done very quickly. And if they are, then you gain really important information that will help you have an integrated approach to the care that you are recommending or are providing. And then refer only if needed. So as I've said earlier, folks at risk for psychosis are far more similar than they are different. There's a good chance that the services and strategies that you use can help address their issues related to psychosis and their issues related to substance use. But if not, then refer if it exceeds your area of expertise or the capacity of your clinic. Okay, so as we continue to march forward, I thought I would share a clinical vignette. Let me just talk about intervention in general before that. I think when addressing substance use in individuals at clinical high risk for psychosis, I'd start by emphasizing that there's not a robust literature on this specific topic. Generally, two principles to keep in mind include doing what you already do, since people at risk for psychosis are more similar than they are different, and implement integrated interventions that target both substance use and whatever the priority of the client is, assuming, and in some cases that might be psychosis risk. What research that does exist indicates that motivational interviewing, as well as cognitive behavioral therapy, can effectively reduce cannabis use as well as other substances of abuse. These methods help individuals understand their motivations, identify triggers, and develop healthier coping strategies. Now, there is some evidence that pharmacological treatments may be necessary or helpful, but this should be personalized and closely monitored due to potential interactions with different systems within the brain, which also might create a link between cannabis use and psychosis risk. So be mindful and careful there. Psychoeducation, I think, is really important and should be universal for individuals and their families. It helps them understand the dangers, particular of any drug, but in particular note of cannabis, and provide strategies for supporting recovery, which should be a goal for everyone. Collaborative care that involves mental health professionals, substance use specialists, peer support, and organic or natural support networks. All of these things should be thought of as best practices for this very complicated treatment concern. As we consider clinical care strategies for clients with psychosis and cannabis use in particular, this table highlights some key points across three areas: treatment engagement, assessment, and therapy strategies. Now, I'm leaning into the cannabis more here because cannabis is the substance that's linked most to psychosis and the development of psychosis. But engagement and treatment should focus on the client's interests and life goals, prioritizing early psychosis interventions if that's required. But being client-driven and client-centered and strengths-based is really, really important in all elements of care, in particular at CHRP as well. Using motivational interviewing and harm reduction strategies, that can be effective for managing substance use. Ongoing assessment, starting at intake, essential to monitor psychosis and cannabis use, or substances if you want to go beyond cannabis, along with providing feedback on cannabis's effects on symptoms so that the folks can see the negative implications of their behaviors. Family involvement can also help reduce substance use. So when discussing cannabis, ask open-ended and non-judgmental questions to foster rapport and reflection. This tailoring therapy strategies to the client's stage of change can be helpful here as well, as is preparing for challenges and identifying alternatives to cannabis use. This holistic approach promotes effective client engagement, addresses substance use, enhances overall well-being, and is attentive to clinical high risk for psychosis as well. Okay, so I have a vignette here about a young person named Tyler. I'll share with you and then share some thoughts. Now, Tyler is a 17-year-old senior in high school who began using cannabis a few times a week with his friends about 6 months ago. In the past month or two, he's noticed that he sometimes hears whispering voices that no one else seems to hear, and has started worrying that his classmates are out to get him. At first, he felt that smoking cannabis helped him calm down when he worried about whether or not these experiences were real. But lately, he started feeling worse after smoking. He reports that the voices sound louder and are more distracting when he's high, and he sometimes worries that his friends want to cause him harm. These experiences have caused him to isolate and smoke alone more often than he used to. His parents have expressed concern about his cannabis use due to a family history of substance use, but Tyler is ambivalent about reducing his consumption. He feels that most of his friends smoke regularly without any problems, and he still occasionally experiences positive effects from smoking, such as reduced anxiety and improved sleep. However, he's starting to wonder whether continuing to smoke is contributing to the challenges he's experiencing. Okay, so some things to think about with Tyler that I wanted to highlight. You can see here, there's some positives or pros. He's talking about cannabis helping him calm down, but then a con, starting to feel worse. Some worries that I'd be concerned about include him isolating and smoking alone. Other folks have expressed concern about his drug use, and there's also family history to be on the lookout for. Peer influence, social influences is showing up here as well. He circles back to benefits or the perceived benefits of smoking, but he has some change talk there. So he's wondering whether he should continue to smoke because maybe that's causing him some challenges that he should be more sensitive to. What about the symptoms? So symptoms that pop up that are relevant here, specific to clinical high risk, is hearing whispering voices no one else seems to hear. His classmates are out to get him. A little bit of paranoia there. The first one, perceptual abnormality. Um, he's worried about whether or not these experiences are real. So he's doubting and questioning things. He's distressed by this at some level, and it's distracting it's distracting for him, especially when he's high. Um, he's worried that his friends want to cause him harm. Again, some suspiciousness or paranoia. And then at the end, it says the challenges he's experiencing. He's interpreting these things as challenges. So we have some idea that these are more than just experiences, these negative things that are happening. They look like symptoms, and they look like they might be related to clinical high risk or psychosis symptoms themselves. So what should we do? How should we consider this? So some ideas for assessment to learn more. We want to learn more about Tyler's experiences. For psychosis risk, tools like the SIPS, which is a specialized structured interview, semi-structured interview for risk symptoms for psychosis, as well as the PQB, which is a short self-report tool that offers insight and can help identify early signs of psychosis, such as auditory hallucinations and paranoia that Tyler seems to be having, and give us more detail, more context, so that we can, in fact, learn more and more information that will be useful. Substance use. We can begin with the tools like the NIDA screen I mentioned earlier to assess cannabis use and patterns of his use, and maybe other drugs that we haven't picked up on. In terms of treatment, motivational interviewing seems like a ripe place to start. He has some ambivalence here. I want to explore that more, explore what he thinks about potentially reducing cannabis use, and how that conversation could help further his readiness for change. Family. Engaging his parents will provide insight into his concerns and explore ways to support Tyler's recovery in partnership with them as potentially supportive people that can help along Tyler's journey. And then the last thing I have here is I'd like to learn more about his functioning, how he's doing. We can assess how symptoms and substances affect his academics, his relationships, his daily life, and more using tools like a global assessment or a global functioning scale, or global assessment of functioning. Variety of different ways that we can help with that. I think all of this leads us to an idea for a holistic approach that could be really useful for Tyler and his family. Like just generally promoting lifestyle change, like exercise, mindfulness, and improved sleep hygiene, as well as being sensitive to the things above, can really lead to a positive outcome for Tyler and his family. All right. So to sum up, we've talked a lot about the connection between clinical high risk as well as psychosis, but clinical high risk for psychosis and substance use, highlighting the need for early identification and sometimes a tailored intervention that addresses both concerns. Clinical high risk for psychosis, it's a significant phase where individuals are experiencing distressing and impairing symptoms, and it might not have gotten to full threshold psychosis yet, but this group is particularly vulnerable to the impact of substance use, especially potentially cannabis. Um, what we want to be on the lookout for cannabis in particular with respect to psychosis are high THC doses as well as early initiation, so when they're younger. Now, the reasons for the associations between substance use and clinical high risk for psychosis and psychosis spectrum disorders is pretty complex, encompassing factors like self-medication, social influences, and neurodevelopmental aspects, just to name a few. We also went through some assessment tools, like using tools like the PQB or the NIDA screening for substance use can be helpful, along with a dynamic understanding of family and functioning and the context that surrounds a person. We've brought up a few approaches to treatment that could be helpful. Strategies like motivational interviewing and cognitive behavioral therapy, while involving family members and supportive adults, can be really useful to 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 long-term outcomes. And I think in general, like my bottom line take home with all of this is proactive preventative approaches. By proactively addressing these issues and their intersection, we can lower the risk of psychosis, improve outcomes for individuals like Taylor in the example that I brought, and others in similar situations. I often talk about early intervention in psychosis and working with people at risk for psychosis as us being on the cusp of a revolution as we're moving towards potentiating positive outcomes and in some cases preventing psychosis in general. Now, for many at risk for psychosis, effectively addressing substance use will be an essential part of our efforts to best serve them and our efforts to keep the revolution moving in the right direction. I want to thank you all for your time and dedication today and for all you do, and appreciate you being here with me today. So thank you very much.
Thank you for joining us for this session in our Early Psychosis Learning Series. The Tennessee Department of Mental Health and Substance Abuse Services extends gratitude to our collaborating partners, the Tennessee Association of Mental Health Organizations and Park Center, for their support in bringing this series to life, and to our presenter, Dr. Jason Schiffman, for generously sharing his time, knowledge, and expertise. Thank you again for your commitment to learning and for the vital work you do. We hope you continue to engage with the series and take away insights that support your practice and the young people we serve.